Hello, everyone. I'm Vincia Pandian, a member of Global Tracheostomy Collaborative from Baltimore, Maryland, in the United States. I want to welcome each one of you to our first session of the Global Tracheostomy webinar for this year, 2020. This has been an amazing year for GTC since we've received a lot of enthusiasm from clinicians around the world who have agreed to volunteer their time by joining various committees within GTC, especially the webinar committee. We're, as always, thankful to our volunteers in various committees, and especially the patient and family committee who inspire us and guide us with our mission to partner with hospitals and providers around the world and to work together to improve the care, safety, and quality of life of every individual with a tracheostomy. This year's webinars are sponsored by Medtronic. However, please note that all our speakers are not funded by Medtronic, and if they are, they will indicate so. To all those of you who are listening, please be aware that you will not be able to ask questions during the panel discussion, but you are encouraged to write your questions in the question section or the chat section that's available. Feel free to include the name of the panelist who you want to answer or who you would like to address a question to. We will answer your questions once all the panelists have finished their presentations. So we really look forward to hearing your questions today. So we have three wonderful panelists, Lisa Malentine and Cecilia Lang from Children's Wisconsin, Milwaukee. Lisa is an amazing respiratory therapist and Cecilia is an astounding clinical nurse specialist, and they both work for Tracheostomy Home Ventilator Program at Children's Wisconsin. Typically, as a webinar committee, we reach out to individuals seeking or inviting them to join our webinar panel, but this year, both of them volunteered to be on our panel, and so I'm very thankful for their passion to share their wisdom with all of us today. We also have Therese Cole, a well-known speech-language pathologist from Johns Hopkins Hospital, very good friend of mine with whom I've shared my academic journey with for over 10 years. So welcome all of you on the panel. To begin, we will be covering three main objectives today. We'll be talking about how to care for mechanically ventilated patients who've received a new tracheostomy tube and how to facilitate speech and swallowing to improve their quality of life and also to prepare them for a safe discharge. At this time, I request Lisa Malentine to speak to us about ventilators and what modes or types are specific for patients with a tracheostomy.
Hi, I'm Lisa Malentine, and for our modes of ventilation, we'll talk about, first off, the ventilation types. There's two types of ventilation that we can provide, which would be pressure ventilation and volume ventilation. Essentially, it will be how the breath is delivered, either by a set pressure or a set volume. The modes of ventilation are either a controlled or an assist control mode of ventilation, which essentially will allow the clinician to be able to set the amount of breaths per minute the machine will deliver to the patient, along with the size of the breath and the amount of time it takes to deliver the breath. If the patient wants to take more breaths than what is set on the machine, they will be able to do so, but those breaths will also be controlled at the size and the time that is set on the machine. SIMV, or synchronized intermittent mandatory ventilation, is a mode of ventilation that allows the clinicians to again set a rate, a size of the breath, and a time that the breath is administered, but it also synchronizes these breaths with the patient's spontaneous breathing. And then we have the adaptive controlled breaths, which are pressure regulated volume control. Again, the clinician will set a rate, and they will set a size of the breath in volume, and they will also set the amount of time it takes to deliver that breath. What it will do is, over a certain amount of breaths, usually about 3 breaths, it will try to control the amount of pressure it takes to deliver those breaths, delivering the smallest amount of pressure possible to minimize trauma to the lungs. Volume guarantee is another adaptive mode of ventilation where there is a specific volume set, and the patient will have a little more control over the aspects of the breath in terms of how fast they want to breathe and how much time it will take to deliver those breaths. Pressure support ventilation is essentially a spontaneous form of ventilation where the clinician will set just a CPAP level, which is continuous positive airway pressure, and the patient will then breathe spontaneously with just a little help of some expiratory pressure to keep the lungs open. Pressure support ventilation will then allow the patient to be able to have a little extra pressure support through the ventilator circuitry to help overcome the resistance of the breathing tube and the tracheostomy itself. The adaptive pressure support, in terms of different modes used, would be volume assured pressure support, where there is a set volume and the pressure support will vary to ensure that that minimum tidal volume is delivered. Volume support acts the same way. We also have an adaptive supportive mode that will allow just one set pressure, and the volume of those breaths will change. We also have a newer mode of ventilation called neurally adjusted ventilatory assist, or NAVA ventilation. This form of ventilation is only available on ventilators in the hospital. And what this mode of ventilation offers is improved synchrony from the ventilator and the patient. What it does is it takes signals from the brain that go directly to the diaphragm, and that is actually captured by a nasogastric tube that goes from the nose down into the stomach and has a series of electrodes that pass the diaphragm. The signal from the brain is then picked up from those electrodes, allowing the ventilator to then trigger a breath. So the ventilator does not need to sense any kind of flow from the patient or pressure from the patient to get a breath. All it needs to do is sense a signal from the brain to the diaphragm. So triggering and synchronization. We have flow sensing, which a pneumotach within the ventilator will sense a flow change from the patient and allow the patient to then trigger a breath from the machine, or pressure sensing, where the ventilator will sense a drop in pressure in the circuitry to deliver a breath. Flow triggering is a much easier form of triggering, and here in pediatrics, we use flow triggering a lot more than we are using pressure triggering, which is a little harder form of breathing on the machine. Other considerations when providing mechanical ventilation would be dead space and resistance. So the area of the circuit where gas can be rebreathed. A lot of times on patients with a tracheostomy and a ventilator, we add extra pieces from the tracheostomy tube to the circuit itself to allow flexibility. All of that extra space or tubing added to that will cause dead space or areas that are not, that are allowing the patient to rebreathe exhaled gas. Air leak is another consideration. We have tracheostomy tubes that are cuffed or uncuffed. A cuffless tracheostomy tube will allow air to flow around the tube much easier, which then can impede ventilation. And then we have humidification. We can artificially heat and humidify the inspired gases from the ventilator. Again, the upper airway is being bypassed, so the nose and the mouth, which normally will humidify inspired gases, are bypassed by the tracheostomy tube. So an artificial means of humidity is necessary to ensure that secretion stays thin and reduce the risk of plugging the tracheostomy tube. Alarms and troubleshooting on mechanical ventilation. We have a series of pressure alarms, the first one being high pressure, or meaning something is in the way. So that can be secretions that are blocking the tracheostomy tube itself from a lack of or improper humidification. Or we can have blockages in the actual ventilator circuitry itself. We could have kinked tubing that could be pressed up against bedding or the patient itself. Also, when we have an artificial means of humidification, condensation can build up in the circuitry and cause a lot of water that will slosh back and forth within the tubing itself and cause a high pressure situation. Also, anything, again, that is in the way, coughing, hiccuping, laughing, crying, anything like that can cause a high pressure. Low pressure or something is missing could be a disconnection of the ventilator circuitry from the tracheostomy tube itself, or a loose connection in the circuitry also. When we're using artificial humidification, the circuit will have temperature probes and wires within it that could pop off. So after thoroughly inspecting the airway, we work our way down the tubing to make sure all of our connections and tubing is tight. Lastly, we have our low minute ventilation alarm. Minute ventilation is the amount of ventilation returned back to the ventilator in 1 minute. If we have a decannulation situation where maybe our tracheostomy tube comes out and remains on the end of our ventilator circuitry, we may have enough resistance in that ventilator circuitry to not trigger a low pressure alarm. But what we won't have is air returning back to the machine itself. So that's where we will have a low minute ventilation alarm. And here at Children's Wisconsin, we prioritize that as our decannulation alarm. Also, when speaking valves are added to the ventilator circuitry, the patient will also not be returning exhaled volume back to the machine. So then you would also expect a low minute ventilation alarm.
Thank you, Lisa. Now I invite Cecilia Lang to share with us some clinical pearls on how to care for a patient who's mechanically ventilated through a tracheostomy tube.
Thank you. Good afternoon and evening, everybody. So I'm going to focus a little bit on positioning your ventilator patient in the immediate postoperative period and just some key care guidelines while you're caring for your patient in an inpatient setting. So here in the United States and also in Canada, we have a collaborative through the Children's Hospital Association. There are many hospitals that belong to a group called Solutions for Patient Safety, which is a quality improvement initiative. So we have many bundle elements that are evidence-based or expert clinician-based. And many of those are able to be implemented in the immediate post-op period to safely care for your patient. One such example is our respiratory device-related subgroup, which I'll talk a little bit about the bundle elements on the next slide. The other thing to consider in the immediate post-op period for your ventilator-dependent patient is your sedation. And in most organizations, this is intensive care unit driven. So your intensive care doctors are partnering with the other care providers to make sure your patient's level of sedation is where you need it to be to effectively ventilate and also safely care for your fresh tracheostomy tube and prevent adverse events such as accidental decannulation or fistula formation. There also usually is a standard postoperative order set that is managed by your ear, nose, and throat team or your tracheostomy team in your organization. So just a little bit about pressure wounds. I know we've had webinars in the past where we have focused on this. So we often see, at least in pediatrics, that these events are more likely caused when patients are connected to the ventilator circuit. So our immediate post-op patients, most of them are ventilated for at least 24 hours, or if they're going to be ventilator dependent, they may be ventilated for longer periods of time. So the bundle elements to prevent wound and pressure injury are very important in the immediate post-op period. So some of the bundle elements you can adopt are assessing around your respiratory device. So clinically looking at your fresh post-op site and doing a thorough skin assessment on a regular basis. Cushioning and protecting your skin with some type of foam dressing under your respiratory device or your tracheostomy tube. And then with your ventilator patients, one of the important things is regular frequency of offloading of your device, your straps, your tubing every 6 hours. So here at Children's Wisconsin, we do trach skin rounds every Friday, and our trach and ENT team is seeing these patients daily when they're in the immediate post-op period. One of our bundle elements is really to make sure that ventilator circuit is staying midline with the patient's tracheostomy tube, and that you're repositioning that circuit from side to side as you're moving your patient to really offload pressure on that fresh tracheostomy stoma. And then also assessment of proper fit. So checking your ties and how much torque is pulling on your trach at least every 6 hours is another recommendation from the bundle elements. So this picture is a little exaggerated, but I use this with our NICU and PICU nurses to really emphasize the how big we want your dressing to be in the immediate post-op period. So usually the ENT team will change the tracheostomy ties at day 3. Unless it's a critical airway, then we may not choose to change those ties unless it's clinically indicated, and it is always done by our ENT physicians and physician assistants. We do provide opportunity for daily skin assessment in all of our patients, and then our pressure reduction dressings, we actually a couple years ago switched to flip the wider part of the dressing to be under the patient's chin. In pediatrics, especially with our neonatal patients, they are at more risk for breakdown underneath their chin, so that's why we emphasize protection of that area. And we also emphasize cutting the dressing wide enough so that the neck isn't getting pinched right where the ties are connected to the flanges of the trach. We also have that swivel adapter on there for patients that don't have a proximal extension. That's one of the things that has allowed us to move the ventilator circuit easily with the patient and offload pressure. And all of our patients at Children's Wisconsin also have wound and skin consults for all of our at-risk patients. A little bit about ventilator and humidity tubing placement. So as Lisa was talking, these heated wire circuits tend to have a lot of water that will slosh around when they're connected to the patient and a heated circuit. So we emphasize with our nursing staff and even our patients and families to make sure that you're threading your tubing through the side rails or through the crib rails so that you don't have a collection of water that occurs close to the patient's tracheostomy tube, leading to inadvertent water getting into the patient's trach tube. We don't want that to happen because it can cause all sorts of things from, coughing, gagging, desaturation, to even chemical pneumonitis. So we emphasize, again, threading that trach and ventilator circuit through the side rails. And even when our patients go home, for our pediatric patients, if they're going to be in a pack and play, we partner with our DME companies to actually cut a hole in the side of the pack and play so that they can thread the tubing through the pack and play to keep it level with the patient and all the water draining down. Another consideration for your hospitalized patients, many organizations across the US and probably worldwide talk about ventilator-associated pneumonia or ventilator-associated events. So we abide by those guidelines and, again, bundle elements for prevention of ventilator-associated pneumonia or events. Some of those bundle elements include inline suctioning, which we will talk about next, and also having dedicated suction tubing for both oral suctioning as well as for tracheostomy tube suctioning. We use this health facts for you. It's one of our teaching sheets that we pass out to families and patients when they're in the inpatient setting so that they understand the care in the hospital for ventilator-associated events and pneumonia may be different from when they go home. So just a little bit about suctioning with a tracheostomy patient who's on the ventilator. We very much emphasize with tracheostomy patients that the suction depth must be pre-measured when it's either inline or when you're doing open suctioning. So when you're looking at your inline suctioning device, there usually is a sheet of paper either at the head of the bed or in the patient's room, and also documented in their medical record for how far down you're suctioning with each suctioning pass. We emphasize suctioning for less than 5 to 10 seconds and allowing the child to return to baseline. When we're suctioning a tracheostomy tube, different from an endotracheal tube, we practice applying suction on both insertion and withdrawal because most of the time the patient is already coughing those secretions up into their trach tube. So we want to get them out as soon as we can instead of pushing them back down into the airway. The other key piece of suctioning your vent-dependent patient is your oxygen breaths via the ventilator. So if you're suctioning with an inline suction device, you can administer some oxygen breaths on the ventilator if it's indicated for your patient.
Thank you, Cecilia, for sharing with us how even as simple as selecting the size of suction catheters or other similar devices are so important when it comes to caring for patients with a tracheostomy, especially those who are on a ventilator, to prevent airway injury. Therese, would you please share with us your experience in promoting speech and swallowing among patients who are mechanically ventilated and require tracheostomy?
Sure. So I'm excited to be here to talk to you all today. So communication and swallowing, my talk is primarily focused on the adult population because that's where most of my experience is. So kind of shifting gears from our peds group now to adults. But we know communication is critical for these patients, and the literature is really pointing us in that direction. There's been some great work by Linda Morris in 2015 talking about how patients report feelings of frustration, fear, anxiety, and powerlessness related to their loss of voice. I don't know about you, but I've had probably dozens of conversations today where I've expressed myself, expressed my needs, talked about my opinions, where many of our patients with tracheostomy tubes who are mechanically ventilated go for days without being able to say a single word. And this can be really detrimental for our patients. So we know that early communication can actually improve their quality of life and reduce their and improve their engagement in their care, with the hopes that this can reduce delirium. So I'm going to talk to you about some of the options for communication. So we know communication is not always easy with these patients. There's lots of barriers that we run into as care providers with mechanical ventilation with communication. So I'm going to talk to you about some of these barriers and then hopefully provide some solutions. Okay, the wait. Waiting till patients are off the ventilator. some institutions wait until patients are no longer mechanically ventilated before trying a speaking valve or doing some sort of leak speech. However, this is not something that we need to practice. The literature tells us, there's been a study by Dr. Freeman Sanderson over in Australia, taking a look at randomizing patients into doing the speaking valve early, so on mechanical ventilation, or waiting until the patients are no longer requiring mechanical ventilation. So she did a randomized clinical trial looking at 30 adult ICU patients and found that the early intervention, which allowing the restoring of communication significantly earlier than waiting till the patient is off the ventilator, they found no complications, which was great for these patients. And they also found that there was a median of 11 days sooner to restore phonation, which is also wonderful. There's another study out of Australia, several studies by Dr. Sutt and colleagues, looking at that the speaking valve not only is safe and feasible, but it actually has some benefit. She looked at electric impedance tomography and found improved end expiratory lung volumes in these patients with use of speaking valve, and found that hyperinflation did not occur with the use of the speaking valve. So it's safe, it's feasible, and there may actually be some benefits for our patients. So we know we can try the speaking valve with patients, and usually we do this in collaboration with respiratory therapy to make sure we're manipulating the ventilator in the appropriate way to restore communication. But are we able to leave the valve on for these patients? So it's great, we can go into the room, we do this speaking valve assessment, we get our patients talking, and then we have to take the valve away, put them back on the ventilator, reinflate the cuff, and which, you know, give them this 30-minute window of speech and then take it away. So what can we do? What can we do about extending that time? So here at Hopkins, we do multidisciplinary tracheostomy team rounds. And through that, we were actually able to increase the time patients were able to use the speaking valve by collaborating with other professionals on the tracheostomy team. So the respiratory therapist, the nurse at the bedside, to talk about what are some ways we can actually increase wear times for these patients. Through that, we found that our policy sort of impeded us from using this for prolonged periods of time without respiratory therapy being right at the bedside. And through some review of the literature and from discussion with different team members, we found that we could use a mode called the non-invasive ventilation mode, which would allow for us to use the speaking valve for prolonged periods of time without having to continuously silence the vent for that low pressure alarm. So Lisa talked about when you drop the cuff, you have that air leak to the upper airway, which triggers a low pressure alarm. In the non-invasive ventilation mode, what you can do is actually manipulate those alarms so that the vent is not alarming with the drop-in cuff and that leak to the upper airway. It's only going to alarm actually when it's not receiving any volume, so when the patient becomes disconnected from the ventilator. So the respiratory therapist can adjust those alarms for us to allow the patient to use the speaking valve more freely and for longer periods of time. So we actually changed our policy here. We've had patients now being able to use the speaking valve after the initial assessment with respiratory and speech pathology, and after a discussion with the medical team for longer times on the unit without someone right at the bedside. Okay, so we know not every patient tolerates their cuff being deflated and that loss of that tidal volume to the upper airway, sometimes because of their lung function, so patients with stiff, fibrotic, non-compliant lungs, sometimes because of the tube size, so if the tube is taking up too much space in the airway, sometimes because of some sort of upper airway obstruction. So what do we do about these patients who just can't tolerate a speaking valve or can't tolerate a cuff leak for some sort of upper airway airflow? So first I want to talk to you about some options to restore voice with the cuff inflated. So one of these is called above cuffed vocalization, or also called the talking tracheostomy tube. Essentially what this is a tube that has a small lumen that sits above the cuff that can connect to medical air. So when we insert that medical air using a thumb port, so when you put your thumb over that port, that inserts air above the cuff through the vocal cords to allow patients to use their voice, essentially separating respiration from phonation. So they're getting their full support from the ventilator, and they're actually using this external air to phonate and voice. Dr. McGrath over in the UK and his colleagues did a study taking a look at this above cuff vocalization and found that it was safe and feasible in a small cohort of patients. And then here at Johns Hopkins, we also took a look at this same talking trach tube, did a prospective randomized control trial looking at 50 adult ICU patients and really focusing on their quality of life. These patients were patients who were unable to tolerate the speaking valve and their initial assessment, and therefore were trialed with a talking tracheostomy tube and found improved voice-related quality of life in these patients. So talking trach is another great option for these patients. However, is a fenestrated tube still an option? So many of you are familiar with fenestration as an option for allowing that air leak to the upper airway. So we took a look at some of the cases that came to Hopkins, and we looked at 15 cases of fenestrated tracheostomy tubes. 13 of these fenestrations were placed for the restoration of phonation, which actually worked for the majority of the patients. However, we found that 60% of the patients, 9 of the 15, who received a fenestrated trach had some sort of complication from the tube. So either granulation tissue, tracheal malacia, tracheal stenosis. This is still an option, but I want to caution you that there can be some risks associated with it. So really thinking critically about the patient and making sure this is the right option before inserting a fenestrated tube. So if we can't use speaking valve, if we can't do leak speech, if we can't do some of the talking trach or some other way to restore phonation, we need to get these patients communicating somehow, because we saw earlier this can be detrimental to their care, to their engagement, and to their quality of life. So some other options that don't restore voice but allow for a patient to communicate is using an electrolarynx. For those of you who are not familiar, this is a device that actually vibrates the space on the neck, and they mouth words, and that vibrated space creates this robotic voice. We use it often with our laryngectomy patients, but this can be used for patients who are mechanically ventilated with a trach who are just unable to tolerate some other form of communication. Another option is augmentative alternative communication, or AAC. And this can be high tech, like a eye gaze or an iPad, or low tech, like a simple communication board. So not every hospital or not every facility has the ability to have high-tech devices like iPads or eye gazes. But what I would encourage you to do is take a look at the Speaks program. It's a free online learning module from Mary Beth Happen colleagues. It's SPEACS. It's 6 10-minute modules that talk about optimizing communication with the nonverbal patient, and they provide you resources about how to set up a communication cart in your ICU. So optimizing communication with those nonverbal patients. So my last weight is, can patients on the ventilator, my patients on the ventilator and they can't eat? So we know from a recent systematic review by Skoratz and colleagues that dysphagia is prevalent among our tracheostomy patients. They found that 40% of trach patients have some type of dysphagia. So we know that this is critical to objectively assess these patients. They are at high risk of aspiration and developing pneumonia in the setting of, most of them have had some sort of prolonged intubation, which can affect the pharynx and larynx, as well as the tracheostomy tube itself actually changes the normal pressures that we are required for swallowing. So instead of having this nice closed system to build up normal subglottic pressure for swallowing, now we have this open system where we're losing pressure out of the airway. In addition to that, the patients on the ventilator makes it hard to fully assess them because they're trying to coordinate their breathing and their swallowing with the ventilator. So being able to objectively view that is critical. So that an objective assessment is either a fiber optic endoscopic evaluation of swallowing or a modified barium swallow study where we can actually visualize what's happening with the swallow. But both of these can be done on the ventilator. The FEES is often easier to coordinate because it can happen at the bedside, whereas the MBS has to happen in radiology. So it does take some coordination with transport. So in conclusion, we want to ensure that our patients have some sort of way to communicate while they're on the mechanical ventilator, whether that be voice or AAC or some other option. The goal is to restore their voice first if we're able. However, if not, we need to find another means for them to communicate. And then finally, objectively assessing the swallow function in our patients who are mechanically ventilated with tracheostomy tube is essential for ensuring safe swallowing while mechanically ventilated. Thank you so much.
Thank you. That is a lot of barriers that we impose on our patients. So thank you, Therese, for enlightening us on how to address some of these myths that serve as barriers to improving quality of life of our patients. Lisa, one of the biggest challenges that clinicians typically face is when patients require prolonged mechanical ventilation, but then otherwise they're ready to go home. I often get calls from intensivists asking me what the next steps are or how to even go about sending a patient with a ventilator, with a tracheostomy home. And I know you work very closely with patients who are frequently sent home on a ventilator. So can you please describe what steps you take and how you prepare your patients for discharge?
Absolutely. So first of all, our teaching and education here at Children's Wisconsin starts right away after the tracheostomy is placed. We identify two caregivers that will be one will be a primary caregiver of the child and the other one will be a secondary caregiver, but two caregivers have to be identified. Each caregiver will receive our stepping stones to home after tracheostomy. Each of these color-coded stepping stones essentially have their goals of teaching in order to be independent in taking this child home. So the caregivers, oops, sorry. Yeah, okay. You can move on to the next slide. I'm sorry. So the caregivers are encouraged to be at the bedside as much as possible. The bedside staff will include the caregivers in the beginning portion of the stepping stones, which would then allow these caregivers to identify why the tracheostomy tube was placed, identify difficulty in breathing, observe the bedside staff performing tracheostomy cares. The first tracheostomy change is done by the ENT physician after 1 week. After that first tracheostomy change, then these caregivers can start performing tracheostomy and stoma cares, cleaning of the stoma and the tracheostomy tube. They can start observing and even doing a tracheostomy change. They can also start learning how to suction the tracheostomy tube and use the manual resuscitator device along with the suctioning. They can also start to identify the emergency go bag And that would include all of the emergency supplies that are needed for the actual tracheostomy tube itself. That emergency supply bag is encouraged to be with the patient at all times when they go home. Moving forward, we will then choose a durable medical equipment company or a DME company for ventilator and tracheostomy supplies. We keep this company updated on the families or caregivers' progress in their education. The DME company will then come out to the home to perform an electrical inspection of the home, and that just includes ensuring that the electrical outlets are grounded so that the equipment can all be plugged in safely without tripping any circuits. And then at that point, we then start working towards home ventilation settings. So while they're on a critical care ventilator, we start making changes to ensure that they can tolerate a home mechanical ventilation mode. Okay, so once the patient is then stable on a home ventilator, the 2-week clock starts to an estimated discharge date. The equipment company will then schedule some teaching sessions in the home on all equipment that is needed to take care of the patient. Here at Children's Hospital of Wisconsin, we send a mechanically ventilated patient home with a pulse oximeter, a suction machine, 2 ventilators, one that stays stationary and one that's used for travel, or if the ventilator that is stationary is having problems, and then also a nebulizer machine. The respiratory therapist from the DME company will come out and they will essentially teach them on the functionality of the equipment, how to turn it on, how to set up cables and circuitry. Mechanically ventilated patients get about 2 scheduled days of education with the equipment company. During this time, caregivers are encouraged to continue practicing at the bedside with all of the cares, including suctioning, any form of respiratory treatments, whether it be nebulizer treatments or inhaled MDI treatments. Also with medication administration through a G-tube, and also all of their feeding needs. Caregivers will also learn CPR, specifically for a trach tube. We do provide videos that the family has to watch. The bedside RN will also provide a mannequin for practicing chest compressions and manual ventilation during CPR. Home equipment teaching doesn't just stop with the DME company. The caregivers after their session with the DME company will bring necessary equipment here to the hospital that will be vital for them to use when taking their child home, which would include the ventilator, the pulse oximeter, and the suction machine. The caregivers will then get 2 more sessions here in the hospital with the tracheostomy ventilator provider. These sessions, the first session will focus on the clinical application of the equipment. So what do the ventilator alarms mean? How do we troubleshoot those? What do the alarms mean on the pulse oximeter, and how do we troubleshoot that? The battery life of all equipment, making that equipment portable, circuitry, how does all of that go on each piece of equipment? Our second teaching session will then focus on our teach back session and essentially a walk off of the unit. So the caregivers will place their child on all of the equipment that they will use at home, their pulse oximeter, they'll pack up their suction machine, they'll make their ventilator portable, meaning that they will use a portable means of humidification. They will come off a heated humidification and use an HME or a heat moisture exchanger. They will also be hooking the ventilator up to any oxygen if that is also needed as part of their prescription. And they also are expected to gather all emergency equipment in the go bag, making sure that it's fully stocked with everything necessary for a tracheostomy emergency, along with their manual resuscitator device. Once that is all packed up in the stroller along with the patient, then the caregivers, along with the tracheostomy home ventilator respiratory therapist, will take a walk off of the ICU unit. At that time, we tour any outpatient areas, so when they do come back for appointments, they're familiarized with all of those locations. The caregivers are also expected to respond to any alarms from the ventilator or the pulse oximeter, and they are expected to troubleshoot those and intervene in any way as far as suctioning or even emergency tracheostomy changes. Lastly, we do independent cares. Since we do identify 2 caregivers, one caregiver will do a 4 to 8 hour session during the day, and this will be on their own. The second caregiver should not be there in the room. Medications and feedings will be scheduled and posted in the room by the RN so that these caregivers all know when feedings need to take place and when medications are due. All home equipment will be placed on the patient. The caregivers will then be expected to respond to and troubleshoot all alarms. Respiratory treatments will be administered by the caregivers, and all G-tube medications and feedings will also be given by the caregivers. During crossover of caregivers, going from primary caregiver over to maybe our secondary caregiver, or the person that will be spending the night with the patient, they will be allowed to do all of the 2-person cares, which would then be cares of the tracheostomy tube and tie changes, tracheostomy change itself, and it's highly encouraged that the child, since both caregivers are there, be packed up into the stroller and again taken for a walk off of the unit so they can continue practicing their skills in packing up that stroller and gathering all necessary equipment for becoming mobile.
Thank you, Lisa, for sharing how you use a standardized protocol to prepare your patients for safe discharge. Here is a list of references for our webinar today. At this time, let's actually look at all the questions that have been posted by the listeners. So I'm going to pull this up and start asking some of the questions here. So one of the questions here is for Cecilia. Do the person who performs the trach suture it in or use stay sutures?
The question was, does the fresh post-op trach, is it sutured in? Mm-hmm. Or do we use stay sutures? For our pediatric patients, the majority of patients have stay sutures. We do have some physicians, depending on the nature of the child's airway and their age, where they will sometimes mature the stoma and actually suture the trach in place during the immediate post-op period. So we do both.
Mm-hmm. Thank you, Cecilia. The next question is, what if you need to provide some mandatory ventilation while the speaking valve is still in place?
So the patient is receiving mechanical ventilation while the speaking valve is in place. They're still receiving the ventilation mode that they had been previously. We may make some adjustments to things like their PEEP. We may drop the PEEP. We may make some adjustments to their tidal volume because of the loss of tidal volume to the upper airway, but they are still receiving mechanical ventilation. I think that's the question.
Thank you. The next question here is, when you place fenestrated tubes, does someone fit them by measuring the distance of stoma to anterior tracheal distance and posterior tracheal distance, or do you just take one off the shelf and place it? this person predicts that if you have had such high rate of complications, it's probably due to improper fit. And I think maybe I'll try to answer that question, since that study was done in collaboration with me at our institution. So the 15 patients who got fenestrated tracheostomy tubes, it's not that we chose 15 patients. These were the only 15 patients who got it over a 10-year period of time at our institution. So it's very rare that we use them. And when we want to use fenestrated tubes, you're right, we typically get those that are pre-made and available by the company. So the one company that we use typically has only the size 4, size 6, and the size 8. So we tend to use those to see if that fits them. And we obviously do scope them to make sure it's in the right place. We do not do customized fenestrated tubes at Hopkins, mainly because our goal is not to find a long-term placement for them. It's usually for a temporary use. And then once the need has been met, we try to transition them to something else. So if these patients truly required fenestrated tube, it's highly possible that we've tried a lot of other options before we got down to that choice. So you're right, it is possible that it's due to an improper fit, and many times in hospitals we don't have the luxury of measuring those distances, placing those orders, because when we custom order them, they're pretty costly. They're probably like the regular tubes are probably X amount, and this is like 10 times more the cost, and the insurance may not cover, and so on. So there are challenges associated with that. Therese, did you want to add anything else to that?
No, I think you covered it.
There's another question here. Can we get the Speaks links? I think this is the one that you were referring to, Therese. So maybe what we could do is, this is from Michelle Patton. So if you can email the GTC website, contact us. Actually, our contact email is on the next slide. If you can email us, we'll definitely share the link with you. The next question here is, can we please access to the reference regarding the 2019 laryngoscope article regarding above cuff vocalization and quality of life? So that is available on PubMed and several other sources as well. You should be able to search it on the web to get them, but if you cannot, please do contact us and we'll try to get a copy for you. The next question here is, Lisa, what do you do if there is only one caregiver for your child?
Here at Children's Wisconsin, just because of essentially our patients are not required to have nursing at home, it is mandatory that they have 2 caregivers. If a second caregiver cannot be identified, then we really have to get Child Protective Services involved.
Mm-hmm. Yeah,
we do a lot of work before that happens with our social work team and other resources that we have in the community to try and help the patient and family identify second caregiver. They don't have to necessarily live in the same home. They just have to be able to support that patient and their family should the primary caregiver be sick or not available to care for that patient in their home.
Mm-hmm. Thank you. There's another interesting question and very important one. Is there any continuing education after discharge? Since this talk was specific to inpatient, we obviously limited ourselves, but this is a great opportunity to talk about it. So Lisa and Cecilia, do you want to share what you do after the patient is discharged?
Yeah, so after discharge, we do follow up with all of these patients in our clinic. These infants are seen about every 3 months. We do check, it's a multidisciplinary clinic, so they do see a pulmonologist, an ENT, respiratory therapist, the nurse clinician, social work, anybody that will help in their needs or their resources at home. The respiratory therapist's role is to ensure that their ventilation is adequate. So we do check end tidal CO2, and a lot of our population, being infants, will eventually wean from the ventilator. So those are always things that we're looking for. We're always suggesting changes made to the ventilation settings themselves, along with the pulmonologist. We also work in collaboration with the respiratory therapists and the teams from the durable medical equipment companies. So those people are coming in and out of the house. So good communication with that staff is also vital in ensuring that our patients are moving forward in their journey.
Right. And we use every clinic visit as an opportunity for re-education. So while the patient and family are seeing all the different specialists, they're asking the caregivers different questions and assessing their knowledge of all of the equipment and the tracheostomy care. So every time they come to clinic, they're getting an education session, whether they realize it or not.
Mm-hmm. Can you share the bundles for fresh trachs? So Lisa and Cecilia, have these bundles published that they can access, or is this a protocol within your institution?
So the Solutions for Patient Safety, if you go to their website, you should be able to find the bundle elements. Otherwise, I'm happy to get that resource and get it to you, Vincia, to post on the GTC website.
Sure. I think that might be a good resource so we can find a place.
Sure. The main bundle elements that were published are on the slides that I presented, those 4 bundle elements.
Perfect. The next question is, can you explain about the talking tracheostomy tube more? I know that we did a whole webinar about the talking tracheostomy tube, which is above cuff vocalization, and the recording of that video is available on the GTC website. So please do take some time to watch that, but I'll definitely hand it over to Therese to quickly describe the talking tracheostomy tube.
Sure. The trach tube that we're referring to is made by Portex. It's called the Blue Line Ultra Suction Aid. It has an extra line that connects to a small thumb port, which connects to medical air. That air is then delivered through a small lumen above the cuff, not a fenestration, so it doesn't completely open to the trach. It actually just connects to that external talk line. And when we insert air through that talk line, that air is then administered through the vocal cords to allow for phonation.
Thank you, Therese. And there is another person who shared that a few patients that they cared for who used a speaking valve stated that they were able to taste and smell things better with their valve on. Have you come across that with your patients?
Yeah, that's actually one of the main benefits of the speaking valve. It restores that airflow to the upper airway, which allows you to smell and taste. So a big part of taste is retronasal aroma, which in order to have that retronasal aroma, you have to have airflow. To smell, you have to have airflow. And when that airflow is restricted just to your neck, you're not getting that airflow to your upper airway.
Do you ever recommend a size 4 trach for an adult ventilated patient? At least in my experience, I have seen patients with size 4 tubes. I have also seen patients with cuffless tracheostomy tubes using ventilators as well. So the size and the choice of whether it's cuffed or cuffless really depends on why the patient needs to be on the ventilator and what the ventilator setting needs are and what can be accommodated with the smallest size possible. And even if it needs to be cuffless, and I'm assuming with pediatric, most of the times they are cuffless tracheostomy tubes and they're on the ventilator. So those are all options that are possible while the patient is on the ventilator. I know there are a few more questions. I have your names here, so we'll be happy to respond to you privately by email. I want to be cognizant of the time here. So at this time, I want to take a moment to thank all of our esteemed panelists for sharing their expertise. I think it was really wonderful to hear about the protocols and about how to address several of the barriers that we impose on our patients when literature is actually suggesting that we could do more to improve their quality of life. So thank you so much for sharing your expertise with our Global Tracheostomy Collaborative family far and wide. A link to today's webinar will be sent out to each one of you 10 to 14 days after the webinar. And please feel free to share the link with your colleagues who are unable to attend today. Our next webinar is planned to be held in April. More details about the date and time will be coming soon. So thank you, everyone. And please don't forget to check our Global Tracheostomy Collaborative website to join us if you haven't joined yet. Have a wonderful rest of the day.